Dear students, we are in the second part of the topic pediatric neurology, that is cerebral palsy. So continuing from the first slide, so we look for the in spastic cerebral palsy, we look for the spasticity and then the typical sign of spasticity, that is hyperreflexia, clonus, extensor, plantar responses, the Babinski signs and the plantar response abnormal Babinski sign, and then look for, because it is in cerebral palsy, we have to look for the persistence of any kind of primitive reflexes, which is very very important, and it's commonly seen in spastic cerebral palsy. Spastic CP is the most common form of cerebral palsy. If you see 100 children with or 10 children, 7 or 8 of the children will be from this classification. That is, they will have a spastics belong to spastic CP. Spastic CP is anatomically distributed, as I already told you, and we will commonly call them as spastic hemiplegic cerebral palsy child, spastic diplegic cerebral palsy child, or spastic quadriplegic cerebral palsy style. So the topographic classification are three: hemiplegia, diplegia, and quadriplegia. So the early signs of cerebral palsy, the signs suggestive of CP in an infant is abnormal behavior. So before going to this, I just want to mention that you have to please write down that other forms of types of cerebral palsy other than spastic cerebral palsy are already we have discussed about the type in tone, and otherwise we will have uh, hypotonic, that is hypertonic or ataxic cerebral palsy style, athertoid or choric athetosis type of cerebral palsy child. In the choric the athetosis type, there will be involuntary movements. There will be involuntary movements of the child is not able to control the movement. There will be abnormal involuntary movements, rhythmic abnormal involuntary movements, what we call as athetosis type of cerebral palsy. In choric athetosis, it is a type where the athetosis is present. Along with that, what we have is choric athetosis. In choric athetosis, also along with the athetotic type, there will be rhythmic dance like movement. The child will be moving and something like dancing, moving even in sitting position, or in if you hold him to standing, the child will be frequently moving like dancing. So these are the other types of cerebral palsy according to the movement which we see. Early signs of cerebral palsy. So what are the early signs of cerebral palsy? Signs suggestive of cerebral palsy in an infant. We are not talking about a neonate. So after the age of first month, if I see an infant, abnormal behavior. What are the abnormal behavior which are early signs of cerebral palsy? Excessive irritability, docility, irritable child, crying always, are highly irritable, will not be, comforted by anybody, constantly crying, poor eye contact, there is no eye contact, poor sleep, very very bad sleeper. These are the abnormal behavior signs which are early signs of CP. Early signs of oromotor signs are there, oromotor problems which are related to the eating, feeding, that is the mouth and tongue activity, oromotor. Frequent vomiting, frequently vomiting, and poor sucking, that is basically feeding problem. Tongue retraction, so hypersensitivity of the tongue will be there, tongue retraction will be there. Persistent bite, the child will be biting persistently and grimacing. Grimacing, persistently bite, grimacing is common. If the grimacing means look like smiling but is actually not smiling. Poor mobility, poor head control, lack of poor head control, that is commonly by 3 months a child should have head control, what we call as, otherwise called as neck control, neck muscular stability leading to control the head upright in whatever position the child is, that will be lacking, which should be commonly achieved by 3 to 4 months, but for these children it is lacking. That is the first motor, early motor abnormal sign directing towards the possibility of the child having cerebral palsy. Hand preference before 2 years of age. Hand preference, that is the domination of hand, which hand is dominant, whether he is a right-handed person or a left-handed person. That will depend upon the dominance of the hemisphere. And this usually dominance will happen only after the age of 2. Why? Because the maturity of the brain, the early maturity to show the dominance, which because language usually the area which is with the cortex which is going to be dominant. Most of the people are right-handed because left part of the brain is the dominant brain, and that area is controlling their language. So that's why we all mostly have right-sidedness or right hand dominance. So some children's here, especially in CP, we are seeing this because there is a lesion one side or any one side is this is common for hemiplegic type of cerebral palsy, because they will their one hand is affected, so there is no other go, the normal hand and the unaffected hand is going to be a dominant hand. Next one is abnormal tone, poor mobility, early sign is poor head control, hand preference before the age of 2 years, then abnormal tone, abnormal muscle tone. So, some of the early differential diagnosis in developmental disability, mainly the developmental milestones are all affected in these children. So, what are all the problems which can happen? So, in comparison, sometimes the cerebral palsy children may have mental retardation problem also. But other than that, if you classify and see what is happening in cerebral palsy cases and what is happening in mental retardation cases, it's a differential diagnosis and take some factors. If you take risk factors in cerebral palsy, often present all the risk factors which I have mentioned earlier. For mental retardation, mostly all the risk factors are absent. For complaints, for cerebral palsy, the complaint from the parents will be that the child is highly irritable and sleepless baby. For mentally retarded child, the mother or the parents will say that the child is a easy baby. The child is not a irritable baby. For milestone delay, for cerebral palsy children, the early motor milestones will be delayed. For a pure mentally retarded child, the without so we are talking about a purely mental retarded without any kind of epileptic or any other problem. The also here also the delay milestones. Why? Because the mental retardation is mostly going to delay the sensory behavior and also the learning process also. Muscle tone here, it is normally increased in case of cerebral palsy, and mental retardation mostly it should be normal, and very rarely it can be reduced because if it is associated with Down syndrome. In primitive reflexes, it is commonly persistent. That is means it is not normally disappearing. But for mentally retarded children, the primitive reflexes, or what we call as the neonatal reflexes, are going to disappear normally. The postural reflexes, which are very essential for learning milestones as well as gross motor movements, is highly delayed in cerebral palsy children, but in the case of mentally retarded it usually is normal, and sometimes also they may also have delayed appearance. Focal signs normally are appearing in cerebral palsy. Mental retardation, we don't find where the lesion or focal sign. So for a focal sign, we should have a focal lesion. So that is very commonly seen in cerebral palsy. So what are the neuromotor problems faced in cerebral palsy? Most of the time, the major problem is muscular dysfunction, movement problem, posture problem related to movement, problem related to posture. So all this will lead to difficulty with flexing and extending of the body against the gravity. That is what we call as mobility, difficulty in mobility, movement abnormality, movement dysfunction. You have to write out all this in your notes, because it will lead to immobility, it will lead to movement abnormality, it will lead to movement dysfunction. It is going to have problems with movement, as well as all of this will lead to postural problems also. So posture means ability to stand against gravity in a particular, in a alignment. So that will also be affected. So to maintain. So posture is to basically to maintain the line of gravity and center of gravity under the base of support and to maintain an upright erect posture against gravity. So that is not possible here because of the abnormal muscle tone and abnormal movement dysfunction and posture problems. Neuromotor problems will be leading to gross motor functional problems such as rolling, prone to supine, supine to prone, sitting, sitting to standing, sitting to kneeling, kneeling to standing, kneeling to sitting, and sit to stand, and standing with single limb, or then ambulation, what we call as functional ambulation or gait. So all of these will be affected. Basically, there is no area where we can say that the child is not. Most of the time, most of the normal milestone learning process, everything motor learning will be affected, along with some of the sensory learning will also be affected because associated problems. We will be discussing that in the following clips, slides. So impairments. So what are the impairments? Primary impairments, secondary and tertiary, we can classify like that. Primary impairments, secondary impairments, tertiary impairments. So primary, already we have understood that this is related to muscle tone. So muscle tone, movement, posture, so that means balance is affected, strength is affected, selectivity, that is what we call as selective and fine motor movement is affected, sensation is also affected. So muscle tones, it can be spasticity, dystonia, hypotonia, athetosis, choric athetosis, all those comes under the relating to muscle tone. Secondary impairments, secondary impairments, contractures. So all of these problems related to weakness, muscle tone, that is spasticity, everything, what will happen? It will lead to contracture. What is contracture? That is permanent reduction of the length, flexibility of the muscle. If the muscle's flexibility to stretch is permanently shortened, the permanent shortening of a muscle will lead to shortening and lack of flexibility. So this is called as contracture. Commonly we see in the cerebral palsy children, it's a TA contracture, that is tendo Achilles contracture. We call it as equinus deformity, or contracture of the hip adductor muscle leading to hip adductor deformity. And sometimes in the upper limb also we see a lot of deformities in the upper limbs also, because this is all due to contractures. Deformities which are leading, what we call as the structural deformities are spine deformities of spine, maybe scoliosis, sometimes kyphosis, all those kind of deformities can also be seen. These are secondary impairments. So here, as a physiotherapist, we have to you have to restrict, no secondary impairment should happen. So that is the main aim of physiotherapy. So in tertiary impairments, adaptive mechanisms. So what will happen? Because of the secondary impairment, some adaptive mechanisms will happen, and those adaptive mechanisms will again lead to much deformity and dysfunctions, such as knee hyperextension in stance, or in case of contractures, the gripping activity, everything will change. So abnormal, compensatory function will happen. So if you look for the deformity and contractures, we have this is a table on the this thing left side. You can see common sites for contracture. So common sites for contracture in upper extremity and lower extremity is given in one side, and then common site of the common site of deformity is given in the other side. In the upper extremity, common site of contracture is the pronator muscles can go for shortening, permanent shortening called as contracture, and the wrist and the finger flexors commonly go for contracture. So what will happen? The shortened finger flexors will never allow the hand to be open fully. So this is a common, and the wrist will never go into extension. So there is going to be a huge, the active insufficiency, passive insufficiency mechanism, that is a length tension relationship mechanism of the wrist, long finger flexors and the extensors, long extensors are at stake. So that means that the child's ability to have a good fine motor function will be challenged or limited. So these are the areas where the physiotherapist has to play a major role to prevent any kind of such problems after understanding early in an early intervention area. thumb adductors are also going for contraction in the upper extremity.